Hi, my name's Robin Evans. I am a physical therapist. I've been treating patients for 25 years now. I have an expertise in treating vestibular patients. So, anybody that's suffering from dizziness or imbalance. I treat a lot of post concussion syndrome patients and really have a passion for treating all ages of patients, but do also hold a board certification in geriatric specialization. I think one of the things that I love so much about what I do and specializing in vestibular rehab is a lot of people don't know about it and don't know that physical therapy is the best option if you're having dizziness or imbalance or symptoms after a concussion. So I look at it as a very underserved patient population. And I was very fortunate to have my training early on in the early 2000s at a large academic teaching hospital in Manhattan, where I was for 10 years. And they have a very large vestibular center there. I just fell in love with treating these conditions. And I've also been very fortunate. I work in the clinic. I am hands on with patients in the clinic, but I also am the director of Ivy Rehab's vestibular and geriatric residency program. Through this program that's been running for over 3 years now, we have 38 newly certified vestibular specialists, which is just really rewarding for me in my career and where my passion has taken me. I think one of the big sort of draws for me was at how much of an impact you can have in this field, specializing in this type of care, because some patients that are suffering from vestibular dysfunction really have a very poor quality of life. If you're dizzy all the time, you're not getting out and about, and vestibular therapy has excellent outcomes. But more importantly, what we do in many cases can be done in several treatments. So, one of the things I think that drew me the most is treating patients with benign positional vertigo, which can occur after having a concussion or head injury. It's actually a disorder where these little calcium carbonate crystals that are inside the inner ear are displaced due to a head injury or other diseases. And patients will actually experience debilitating room spinning vertigo. And the treatment that we do is a manual technique where we just move the patient's head in a certain way in the clinic. And the literature and what I see in the clinic is that about 80 to 85% of these patients only need 1 to 3 treatments of physical therapy to completely cure that mechanical problem. I feel like it's instant relief for patients. And I think there's so much science behind what we do that I think that was one of the things that really made me realize that this was the area of practice that I wanted to become an expert in and really treat for the rest of my career. In general, a concussion is really a mild traumatic brain injury. And what's happening is that there's some sort of either direct or indirect force applied to the head. It can be a direct blow to the head, but it can also be a translational force. If you're driving in a car and you're involved in a motor vehicle accident, there's some shear forces, translational forces, where the brain, which actually sits in the skull and is surrounded by fluid, accelerates and decelerates. And there is some microcellular processes that occur in terms of cell metabolism. There's actually shearing of neuronal axons. So the axons carry messages throughout the brain. And we know that when there's any injury or insult to the brain, as I described, those axons are stretched and it causes disruption of the ion exchange that helps to maintain equilibrium in the cells communicating with one another. So the disruption can lead to decreased cerebral blood flow to the brain and really this metabolic crisis that occurs. So signals that normally we don't even know are going on, right, within our brain, which is like the hard drive or the computer, to everything that we do. Me speaking to you right now, being able to make eye contact, move my head, my affect, um, everything is controlled by these neural circuits in the brain. And there are lots of ways in which those systems can be injured due to direct or indirect forces to the head, which then gives you a concussion. Some of the misconceptions, and there are many, but some of, I would say, as a clinician, the top misconceptions of people understanding that they've sustained a concussion is many folks think they need to lose consciousness. I didn't black out, so I don't have a concussion, and that's very far from the truth. Also, people think that you need to have immediate symptoms with a concussion. I felt fine and I didn't have symptoms for days, so it can't be related to that. And again, that's really a misconception. We know based on the literature that the symptoms can come on much later after the event. And then another one that I hear all the time is that folks maybe have symptoms and they go to an urgent care or the ER or just their doctor, and they tell me, I had a brain scan, I had an MRI, I had a CAT scan, and everything was normal. But the thing to really understand about concussion is that there is not a structural abnormality that occurs. So it's not a structural injury that can be seen on imaging. It's more of a functional injury, as I described before. And most times, I would say greater than 99% of the time, your MRI and CT scans will be perfectly normal when you've sustained a concussion. Some of the most common symptoms that I see in the clinic are patients that are coming in and reporting dizziness. They feel sometimes dizzy at rest or with head and body motion. There are a lot of complaints of patients that have difficulty with focus and with their vision, believe it or not. So they'll report things like, when I'm reading the newspaper, I feel like I'm losing my place a lot on the page, or when I'm working and I'm on the screen, or I'm in school trying to focus on a screen or some sort of textbook, that they're having difficulty processing information as they did prior to the injury. So I think another thing that we hear a lot is patients report a lot of fatigue. So I think it's important to remember that when the brain has an injury and any of the structures and the normal circuitry of the brain that we normally never have to think about and occur so smoothly and effortlessly, when the brain is under this heightened state of injury, our everyday tasks with reading and comprehending and remembering what we need to get at the grocery store and talking to our neighbor and walking our dog, your brain is in this mode of trying to play catch up. And the symptoms of that come out in a way that most patients, a lot of people are complaining of feeling very tired at the ends of the day, and their normal tasks are quite draining for them. So those are some of, I think, the most common things that I hear in the clinic with my patients who have sustained a concussion. So outpatient physical therapists do a very thorough evaluation. I think one of the most important things that we do and that we do well is take a very thorough history and really listen to our patients. I hear all the time, which is another reason I love my profession, that we are providers that really spend In IV rehab, we get 40 minutes of one-on-one uninterrupted time with patients to really listen to what the patients are reporting, because everything I do is based on patient-centered care. And especially with concussion, because no concussion looks the same. For instance, if a patient comes in and tells me that they're feeling dizzy, I am going to do a full and thorough vestibular screen. So we use the vestibular system, number one. What it does is it detects your head motion in space, and it's actually connected to your eyes through a reflex called the vestibulo-ocular reflex. So when I'm moving my head in space, my surroundings don't move due to that reflex. So as vestibular therapists, we look at the vestibulo-ocular reflex. We put infrared goggles on patients. We record eye movements. Things that you wouldn't typically think a physical therapist does is what we're looking at when patients are coming in reporting dizziness. We also do a full oculomotor exam in room light. So we look at things such as visual tracking, saccadic eye movement. How well do your eyes move from one target to another? Is there what we call a catch-up saccade? So is the brain processing information and then able to make these adjustments seamlessly, right? So if there are deficits, we're skilled at finding those deficits and then linking them to your complaints. If it's that you're finding it difficult to read or you have trouble concentrating, we do things where we're testing your motor function while you're performing a cognitive task. So we have objective ways to measure how much are you slowed down with your cognitive abilities when performing motor skills. So we have a very wide variety of different tests and measures that we use, again, fully based on what the patient's complaints are. Again, back to the patient-centered care model and really using a holistic approach. The main things that I do is I want to return people to their prior level of function, right? Based on what deficits I find, if I find there's a problem with convergence, let's say, which is actually very typical with concussion patients. So convergence, just so you know, is not visual acuity. It is the ability for your eyes to work together to fuse objects. So if I held my finger out in front of me, a quick test, and bring it in toward my nose, my finger should stay in focus until about 5 centimeters before my nose. We see a lot of patients post-concussion have what we call convergence insufficiency. So that's just an example. I'm always checking for that because that can lead to those common complaints we hear: looking at screens, difficulty reading, difficulty with focus and concentration. Maybe athletes are having trouble with depth perception. And then we would do a lot of ocular exercises in the clinic, right? We use, believe it or not, YouTube videos, and we do convergence exercises and tracking exercises. If you need referral to a neuro-ophthalmologist or optometrist, we would make that referral if you needed a higher level of care for the ocular deficits. In terms of vestibular rehab, we do what's called positional maneuvers. So things such as the Epley maneuver, which is a maneuver to reposition crystals that may be out of place if you're experiencing vertigo. If you're having trouble with general dizziness in your everyday life or when your head is moving, we do a lot of what's called habituation exercises. So I have patients walk in my clinic and rapidly turn their head side to side, up and down in diagonal motions, looking at different targets. We also train something called the vestibulo-ocular reflex, and that reflex allows you to keep your world in focus while your head and body are moving. And that causes a lot of problems post-concussion. And we find that system can have deficit. We do a lot of training where patients look at targets, keeping their eyes on different targets with different backgrounds, and they have to shake their head while keeping targets in focus. We put patients on foam pads and Bosu balls. We do ball catching and throwing, all things at a baseline level to build the system back. And then the patient-centered care model really goes on to figure out, what does this patient need to return to their prior level of function? Are they a high-level athlete? Then I have to get them back into those types of conditioning. Can they run at the speed that they need to run and catch a ball? Going through all those motions of therapy and then figuring out, is this a professor that needs to read articles for 3 hours every night and prepare assignments? I have to get him back to being able to do that. So it's a very structured and graded approach where we really take patients through all the steps to return them to the prior level of function. One of, the things that I think is so crucial to understand is that, first of all, a lot of older adults don't know what a concussion is. They definitely are underreporting falls. They may not remember hitting their head, or they may be more focused on hurting their wrists during the fall, or they broke their hip. And rightfully so, the focus needs to be there for whatever is their primary complaint. But what I see in the clinic is that a lot of older adults, after sustaining falls, really, again, because there's this misconception that the MRI was normal and they didn't lose consciousness, that they don't fall into the category of patients with concussion. And what we see is, if we really take the time to listen to these patients, they may be reporting that they're feeling lightheaded when they're getting out of bed in the morning, or that they feel, a big complaint is that they feel very unsteady in the middle of the night when they get up, maybe to use the bathroom. And these patients are at a very great risk of having another fall and another subsequent blow to the head, which can cause another concussion. And we know that when we don't, first of all, uncover that a concussion has taken place in this patient population and understand what those implications are, and work to really educate patients and help them with their balance and fall prevention and preventing future falls and subsequently another concussion, we're really in a position to intervene so that this patient doesn't have long-standing permanent damage due to having a secondary fall and then one concussion on top of another. So just really educating them, and then being able to provide them with gait and balance and fall prevention and vestibular therapy to address their dizziness, to make sure. A lot of older folks have something called orthostatic hypotension. So their blood pressure dips down when they go from a lying down to a standing up position, or they're on medications such as antihistamines or antihypertensive medications that they may need to be on, but it makes them a much greater risk for falling. And that's been clearly documented in the literature. What I try and do is just really screen all the time for falls and really get detailed about asking, did you hit your head? Are you sure you didn't hit your head? If you did hit your head, do you ever experience lightheadedness? Do you feel ever you're a little slower with your cognition or your memory? Are you having more trouble completing any of your daily activities? Do you find it hard to concentrate? And things like that. Do you feel unsteady outdoors? Do you feel comfortable walking on grass in dimly lit environments? Really knowing what the symptoms are and then being able to ask the right questions, I think, gives the therapist an understanding of whether or not patients that routinely underreport concussion helps us to identify them and then intervene to really ultimately give them a better quality of life.